First of all, let me introduce myself. My name is Eiji Furuichi from Kobe, Japan. I have a PhD in dentistry and specialize in periodontology, implantology, prosthetics, and aesthetics. Today, I will present and talk about two of my cases. Thank you very much for inviting me to attend and present at this wonderful symposium. I appreciate all of you for taking the time to hear about my periodontal and prosthetic aesthetic cases. The theme of my presentation is periodontology and prosthodontics. Using periodontal resective therapy, I will show you that teeth can be saved and used in the final restoration process. This is the mandibular first molar case, 5 years ago. The furcation involvement is class 3. Regenerative therapy was performed. 18 months after re-entry, complete closure of the furcation defect was achieved. This is an amazing result. In this case, the patient sincerely hoped to use regeneration therapy to save her teeth. What would you do? Would you suggest that every patient with this condition undergo such treatment? Do you think it is possible to get results like this every time? These articles tell us the answer to those questions. The answer is no. We believe patients should be presented with a treatment method that has at least an 80% chance of success. And now, I would like to begin the presentation of the crown lengthening procedure. I think it's a very important technique, and often we have to use it to save teeth. First of all, I will show you the posterior region. The patient is 66-year-old female. An X-ray of the upper right molars was taken and shows the clinical view after removing the crown. These teeth have lots of problems. What did I do? Is it necessary to do implant therapy? What should we do for longevity and good prognosis? Success. I think it is necessary to do the following. There were end lesions, so I removed the crowns carefully, replaced with temporary crowns, and performed root canal treatment. Periodontal surgery. Plaque control measures were introduced prior to the initial treatment so that the full mouth plaque score was reduced to less than 10%. After achieving optimal hygiene, periodontal surgery was performed. On the parietal side, we made an incision to evaluate the alveolar crest and to make the upper end of a thin flap that could easily be adapted to the crest. Next, careful and minimal osteotomy was performed until the architecture was positive. Care was taken to avoid exposing the buccal furcation, except in the area requiring bone removal. We performed debridement and tooth root preparation using the same method as Carnavale et al. The flap was sutured carefully and gently, pulled apically without tension, so the edges of the buccal and palatal flaps would reach the new alveolar crest. The surgical procedure was performed as non-aggressively as possible. The slide shows data from an article published in 2004 by Axelson et al. These are the results for how teeth were lost after 30 years of maintenance in more than 550 people, aged 21 to 65 years. The main reason for tooth loss was fracture, and most fractured teeth have a screw post or metal core. These results suggest that it is possible to prevent caries and periodontal disease, but it may be impossible to prevent fracture. Hayashi, Takahashi et al. At Osaka University reported that fiber posts are superior to all other abutment posts with regard to resistance to root fracture, while Soejima et al. At Tokyo Dental College found that for META, MMA, TBB resin has the strongest adhesive properties of all cements. Fukagawa et al. At Tsurumi University reported that an indirect approach provides better retention than a direct approach for the fiber post core, while Kanami et al. At Hokkaido University found that for META, MMA, TBB resin has the strongest bioaffinity, biostability, and adhesion. These findings suggest that an indirect approach should be used for fiber post fabrication, with for META, MMA, TBB resin used for adhesion. Here, you can see the preparation for fiber post cores 6 months after surgery. And fiber post cores in the teeth. Roberto Pontoriello and Gianfranco Cannavale reported that gingival growth continued for around 1 year after crown lengthening, with a mean growth of approximately 3 millimeters. Based on these findings, we waited about 14 months after crown lengthening before performing abutment preparation, with the finishing line of the final preparation placed within the gingival sulcus to avoid the gingival attachment. Provisional restorations using the diagnostic workup as a reference. The final restoration used lithium disilicate glass mix. This is the end point. Here is an occlusal view of the final restoration 17 months after surgery. Here is the side view of the final restoration. The probing depth is less than or equal to 3 millimeters. There was no bleeding on probing. The full mouth plaque score was less than or equal to 10%. There was no furcation involvement. This is the end point. Here are the initial and final images. Final images. Follow-up. 60 months after the final restoration and 33 months after the crown lengthening surgery. The patient is doing well. Next, this patient is a 43-year-old female. Here is an initial view. If we can perform the crown lengthening procedure correctly. We can save teeth like this. The crown lengthening was performed. We used the fiber post core set with for META, MMA, TBB resin. We waited more than 12 months after crown lengthening before performing abutment preparation. The final restoration used lithium disilicate glass ceramics and layered zirconia crown. This is the end point. Follow up after 23 months. Here are the initial and latest images. The next case is the anterior lesion. These are very beautiful women. Since we live in a world that emphasizes aesthetics, we should avoid making the teeth look like this by utilizing 21st century surgical techniques. This patient is a 66-year-old female. She wasn't willing to undergo orthodontic treatment. However, there is clearly a problem with tooth thickness and the failure effect. We can save the teeth and establish an endpoint that includes aesthetics and high predictability. This is endpoint. Next, this patient is a 43-year-old female. Her chief complaint was an unappealing aesthetic appearance of the anterior teeth. Here is the patient's face at the initial visit. She is smiling, but it does not look good, and she lacks confidence. This is a primary outcome. The smile at the initial visit. The patient had a dental prosthesis fitted in the maxillary anterior region. However, had the correct endpoints been reached, Dr. Hugel was the first to establish clear endpoints for the treatment period. These include a probing depth of 3 mm or less, a full mouth plaque score of 10% or less, no bleeding on probing, and no Parkinson involvement. However, attaining this intraoral status does not at all represent a state in which the true endpoints have been achieved. Based on a 2008 report by Dr. Lang Nicholas et al., we should reduce the probing depth to less than or equal to 3 mm. Nicholas et al. Found that the greater the probing depth, the greater the risk of tooth extraction. Therefore, we have chosen to make it less than or equal to 3 mm. Mount image. This is a classification of alveolar ridge deformity by Shibert. Class 1. This case is class 1 with wide buccal long loss. Periodontal surgery. Non-aggressive and clean. So beautiful. We open the flap using the surgical template. We carefully performed osteotomy, taking into consideration the gingival margin of the final restoration. During surgery, it is very important to avoid removing more bone than necessary and avoid removing tissue from areas where no removal is needed. Connective tissue was sutured into place. Suturing was done gently, without tension. By 1 year after surgery, the gingival margin had increased about 3 millimeters, which is important to considering when forming the bone, setting the flap, and suturing. Here is a comparison of the initial and postoperative occlusal view. The width of the alveolar ridge was increased in the area around the missing tooth. We made a fiber post core set with for META, MMA, TBB resin. We created a mock-up and performed the preparation carefully and precisely, and checked whether the amount of tooth reduction was uniform using the silicon index. After that, we completed the preparation by setting the finishing margin line slightly shallow without damaging the tissue. This was performed 9 months after surgery. We made another diagnostic workshop and used it to create the final restoration. We decided on the inclination angle, line angle, shape, interdental space, and surface wave before checking the final form. Final restoration. Final restoration, 10 months after surgery. We used layered zirconia crowns. The tooth edges were set based on the upper anterior teeth. We were able to achieve a beautiful outcome. Here are initial and final restoration images. Initial view, final view. Here, you can see a picture and an X-ray of the anterior teeth. This is the patient's face and her smile at the end point. We succeeded in creating a beautiful smile. This is the end point. We were able to create a final restoration that took into consideration the following aesthetic factors: tooth position, shape, size, length, color, tooth edges, embrasured space, cervical line, amount of teeth visible, when the lips are in the mandibular resting position, or when smiling, and the harmony between the teeth and lower lip and face. Furthermore, when biting, the left and right teeth contact should be even and make contact at the same time. And the anterior coupling and disclusion at the molars should also be considered. In addition, The periodontal tissue is healthy, with no bleeding. All probing depths are less than or equal to 3 millimeters, and the full mouth plug score is less than or equal to 10%. The patient was very satisfied that we could achieve a successful outcome. Here is a side view at 22 months. The best reward is our patient smile. Here are my mentors. If I hadn't met them, I wouldn't be here now. Thank you so much. Thank you for your attention.